Hello, I'm Dr. Paul McGahey, and I'm excited to give our talk to the virtual Pediatric Trauma Society meeting. Our talk is entitled The Need for Surgeon Presence and Need for Trauma Intervention, both outperform ISS in predicting resource utilization in pediatric trauma. For a little bit of background, injury severity score is the current standard for assessing triage appropriateness and predicting resource utilization. This scoring system was originally developed for the adult population but has been applied without modification to the pediatric trauma population. Need for surgeon presence and need for trauma intervention are more recently developed scoring systems which could also be used to help determine triage appropriateness. These scoring systems are most of the time able to be calculated almost immediately after leaving the trauma bay. If not then just several days after, rather than the ISS scoring system, which can be delayed up to many days post-patient discharge. For a patient to be NSP positive, they must have one of the following definitions, including things like intubation, vasopressor requirements, spinal cord injury suspected. In order to be NFTI positive, the patient needs any one of the following, and things like need for non-procedural mechanical ventilation, ED discharge to the interventional radiology suite, things of that nature. The purpose of this study was to compare NSP, NFTI, and ISS in predicting mortality and resource utilization, and thus determining which may be a better assessment tool in triage of pediatric trauma patients. Our methodology included utilizing the Trauma Quality Improvement data set. We used the data from 2016 and 2017. Outcomes of interest included things like mortality, length of stay, disposition from the ED, and discharge disposition. We also used multivariable logistic regression models adjusting for age, sex, injury type, and transport mode to look at prognostic values for NSP and NFTI in regards to them contrasting with the injury severity scoring system. Our population included 54,000 patients. All of them were pediatric trauma patients less than the age of 18. 148 were excluded for missing data points. The majority of them were male at 64%. The age groups were relatively even across ages 1 through 17. The overwhelming majority of injury was blunt injury at 91%, which is not unexpected, and 2.1% of this population died. Looking more closely at our data, we are looking at the comparisons of NSP positive patients, NSP negative, NFTI negative, NFTI positive, ISS greater than 16, and ISS less than 16. Breaking this down, we'll look at a few of these in the fact that NSP or NFTI outperform ISS systems in each of these categories. First, looking at the OR from the ED, NSP positive patients had 23% of this group, whereas NFTI was able to capture 38% of these patients. In the ISS system, the ISS greater than 16 was only able to capture 15% of these patients. Next, looking at hospital discharge to rehab, NSP positive was able to capture 77% of these patients, NFTI positive was able to capture 82%, and ISS of greater than 16 was able to capture 75%. Looking at deaths in the ED, NSP positive was able to capture 89% of these, NFTI positive was able to capture 87% of these, and ISS greater than 16 was only able to capture 76% of these. Finally, looking at overall mortality, NSP negative patients were only 61 in total in regards to mortality, NFTI was only 69 in total, and ISS of less than 16 had 138 mortalities in this group. Finally, looking at the area under the curve and our logistic regression modeling, our multivariable models adjusted for injury type, age group, and mode of pre-hospital transport, all 4 indicators showed very strong association with mortality. The AUC was very high for each of these multivariable models, as well as a single variable model. Though the raw difference was small, based on AUC, contrast statistics, the AUC for NSP was statistically higher than both NFTI and ISS greater than 16. For discussion, we found that NSP and NFTI consistently outperformed ISS in determining mortality and resource utilization in the pediatric trauma population. And this reveals a real need to reconsider what metric we are using to evaluate our pediatric trauma patients. Developing a pediatric trauma injury severity score based on the NSP/NFTI system, maybe a combination of both, could lead to a better assessment of trauma triage criteria for pediatric patients. Our study did have some limitations. With our large data set studies, this was not originally intended to look at NSP and NFTI specifically, so that is one of our limitations. Secondly, some data was missing, which is the nature of large data set studies. And finally, the criteria for NSP and NFTI are weighted with equal importance, although it's possible, not only possible, but probable that some of these criteria may have stronger associations than others. In conclusion, NSP and NFTI consistently outperformed ISS in multiple outcomes of interest, and both may provide a better assessment for accurate pediatric triage. NSP may offer some advantages over NFTI, including things like it's able to better predict increased length of stay, fewer discharges home, more discharges to inpatient rehab centers. And further research into this potentially combining variables from each of these systems into a novel pediatric scoring system should be considered. These are my references. I thank you for your time.